Yes.
Yes. Yep. Yep.
Okay, great. Okay. I decided to call this the hegemony of normal psychiatry, and an attempt to explain how abuses become normalized, especially unpleasant and painful treatments. Electroconvulsive therapy is one of my main examples of this, and how it's used in India and the US. And to do so, in terms of the topic of this session, let me just, I realize I can't see the time on my screen, so I'm just making sure I have my phone here to keep me up on what time it is. Okay. So, you know, the description for this meeting discusses political abuse of psychiatry involving what we might call explicit forms of power, you know, very an oppressive state where, you know, dissidents are branded mentally ill, where incarceration, you know, with the justification of mental health is used. And one of the first things that comes to my mind in terms of this presentation of power comes from social theory, the social theory that I teach in history of theory and in anthropology classes. And I want to say a few words about that. These may be theorists that you all know well, but I want to think about political abuses of power not in a situation where the political abuse is directly, you know, boldly and blatantly political, like, you know, diagnosing dissidents, although that happens. I want to discuss the political abuse in a place where the politics is less explicit, less clear. Certainly, we could see, you know, if we looked at the Soviet Union or today's Russia under Putin, a very explicit regime of power where you know where the power is, and you kind of know what you can and can't say, and you can easily be, you know, in prison just for being someone who, you know, runs for political office. But psychiatry can be abused in the interest of the state, and but in many societies, I don't know, perhaps most societies, I'm not sure how to quantify this, you know, a place that is not a fascist country, you have political power happening in a more subtle way through processes such as those that Antonio Gramsci and Michel Foucault have examined. You may know Gramsci's work on hegemony. Sorry, just a second. Let me there's a dog scratching my door. I just want to let it so he doesn't scratch. So Gramsci, if you don't know his story, he was imprisoned by Mussolini and wrote a series of writings on social analysis that has been published as the Prison Notebooks. And he wrote both about the, you know, explicit domination, which is what he was experiencing as being a dissident in Mussolini's Italy and being imprisoned for his politics, and what he called hegemony, which is the more subtle, equally powerful set of ideologies and politics that are not recognized necessarily as being part of the system of power. And in social theory, many of us have adopted the idea of hegemony, you know, that there is a, you know, a hegemonic way of thinking that dominates in society. But the key idea in hegemony is that the people who adopt the thinking, even if it's not in their interests, they still take it to be just common sense, rather than something that's coming from, you know, those with power. It's sort of everyday forms of power that doesn't speak its name and is not obvious. These taken for granted forms of common sense that we just think of as natural, that are in fact produced according to certain interests, not in a conspiratorial way. The, you know, people with power tend to depict the world in the way that they think is simply real, but it is actually their privileged perspective, and many people will just adopt those views as common sense. And Michel Foucault, probably the most influential social thinker since, I don't know, maybe Max Weber or Karl Marx or Emil Durkheim, took power in his writing out of the explicitly political as well, and showed us how power is everywhere, even in, as he says, the capillary forms, the little tiny everyday behaviors and assumptions through which it is acted out. And he was famous for also putting the world of medicine and the world of mental health in the world of power. The medical system was not something that was absent power. Power and hierarchy were shot through with it. And this isn't just the power where, like drug companies have money, that kind of obvious power. It is the power that, again, is more subtle, but very powerful, where he discusses public health. Public health involves counting the population and finding out who, has what illness, and how the state can manage a population given that information. It involves collecting information on populations. People, when they're living in these countries today, sort of a normal democratic state, by being counted and by interacting with the state, become surveyors. They surveillance is taught to people, and they kind of restrict themselves. That's the modern subject, according to Foucault. So both of these thinkers discuss how power and hierarchy operate in really everyday life in non-explicit ways. And I bring those up because the kind of political abuse of power that I want to discuss in India and the U.S. through psychiatry is happening in this way. Not because it's not the state, rounding up a cabal of dissidents. It's the common sense of psychiatry, and the abuses that come with that. That's why I call this the hegemony of normal psychiatry. I'll say a few words first about the work I've done in India, and one of the claims I've published. I did field work at several points since the 1990s in southern India, in the state of Kerala. And in that research, I focused on the three major forms of therapy for mental health problems, and those are, as you see in the slide, psychiatry, Western psychiatry. It goes by many different names in India: allopathic medicine, English medicine, and I put the term biomedicine in there because that's what medical anthropologists, my field, uses to designate this general hegemonic medical system that's around the world that doesn't really have a label often other than medicine, or sometimes it's Western medicine. Biomedicine was invented as a term to get away from the Western idea, because it is a global medicine now. Anyway, biomedicine is not a perfect label either. But to move on to Ayurveda. Ayurveda is the largest indigenous medical system of India. It's institutionalized in the forms of clinics and hospitals. It's not quote unquote traditional or folk healing or anything like that. It's an elaborated medical system with a pharmacopoeia, medical literature, research journals. It's a system of itself, and it is practiced pretty significantly. The psychiatric side of that, the focus on mental health in the state of Kerala, India.
I'm sorry, Murphy.
Yes.
Your slides, they are not moving.
Oh, they aren't? Oh.
No.
Okay. Uh-oh. I wonder why that.
We can only see the title slide.
Oh, you're still on the first one. Okay.
Yeah, I'm sorry I didn't say anything, but yeah, I was checking.
Let me see. Let's see. I'm clicking on start from the beginning. Okay. do you see the second slide now?
No.
Well, that's unfortunate. I wonder what is the glitch. I wonder maybe it's the browser I'm using, or
Can you just double click on the second slide you want to use?
actually, I'm seeing now that I'm back on. I was looking from the slides. Let me just see if I can. Now that I'm looking on the Google Meet screen. Maybe that helps. Sharing your entire screen or browser can cause an infinity mirror. Okay. Maybe I need to ignore that. Let me. And on the.
Yeah, there you go. That's it.
Yeah, now, yeah.
I think it seems as if I toggle between the PowerPoint and my browser, I guess that makes it work. So I'll try. So anyway, I'll just these are some of the slides that correspond to what I've just said, and having given a bit of social theory about this way of looking at power. Let me move the PowerPoint to, and I had a map of the state of Kerala to locate where I've done work in India. Are you all seeing that? Okay, I think I've got it now. And then the three the three systems of medicine I was discussing are listed here. I think I was talking about Ayurveda and the use of Ayurvedic psychiatry in India, and then religious therapies. I went to Muslim, Christian, and Hindu sites that are known for healing mental health problems, which may appear in other idioms, such as spirit possession, and a variety of ritual engagements are used to help people get over these problems. And these were, I interviewed people in all these different systems of therapy, came up with a bunch of different claims about stuff, but I'll just mention one of them that has to do with what one might call an abusive form of medicine. This is the sign outside a government research institute for mental diseases. Is actually a hospital, an Ayurvedic mental hospital that I visited. And one of the things I noticed at this hospital, I'm just going to give you one slide of one treatment intervention I was observing, Halliburton, which is involves, there's no really vocabulary or translation for this. I call it a medicated mud pack. You see that being packed down upon a patient's head. It's not actually mud, it's medicinal plants bound with yogurt and kind of pureed, and it looks like mud. And they do a variety of inpatient treatments at this Ayurvedic mental hospital, such as this one, several others involving medications too. When I spoke to the patients there, they said they liked how the therapy feels. The mud packs made them feel, as they said, calm and cool. They put it on for like 45 minutes. They replace it after a while with some new mud. It actually gets warm right here in this part of the head, and they replace it with new mud. There's these steaming treatments that are done as well. They're in a way, the treatment reminded me of a spa treatment. And because, well, actually, and interestingly, if you go as a tourist to an Ayurvedic resort in Kerala, India, you can get the same treatments the mental hospital patients get by paying for them under idioms such as Ayurvedic massage. And so, which I think sort of underlies what I thought was very important to me. I decided there's something pleasant to this form of treatment, which I think the patients appreciated. And I couldn't help but think about how that contrasted with the treatments I saw at the mental hospitals in right there also in Kerala, where they used Western biomedical psychiatry, and they used high doses of antipsychotic drugs and electroconvulsive therapy as treatments. Those treatments were perceived as unpleasant, as painful. They were even perceived as punishment. by some of the patients, many of whom left to try another form of therapy, such as Ayurveda or going to one of these religious sites. So I interviewed patients and family members about this and got this sort of picture of how, the pleasantness or unpleasantness of the process of therapy is a factor in therapy and may cause people to abandon a certain treatment in favor of another one. And in fact, I even tried to quantify this. This is a little, just an excerpt from an article. I have it in this edit format, so it says click to add title, but hopefully it's easy to read. Which showed that basically patients offered complaints about the effects of psychiatric medications and ECT regarding their biomedical allopathic therapy, but not so with Ayurvedic therapy. Ayurveda, I argue, is a gentler therapy. It is not as abrasive. Put in starker or bolder terms, it is less abusive. I published an article called "The Importance of a Pleasant Process of Therapy," and I wasn't thinking abuse as I was for this for this meeting. But you could also use that category, abusiveness, not abusiveness, in addition to pleasant, unpleasant. And okay, going back to, so here, I want to just reference a couple other books in this. Oh wait, no, Google Meet is asking me something. I'm just going to ignore. It wants to know if it can send me notifications. So Sayuba Varma, this book, The Occupied Clinic, came out recently, and it's an examination of mental health care in Kashmir, India. And what she discusses is how Kashmir is a very different place from Kerala. It's under Indian military occupation, and it's a very restive state with military presence and mass arrests and detainment of people who are suspected of being militants and separatists. And probably the best simple illustration of what Sayuba Varma tries to tell in her book is there is a location in Srinagar, Kashmir, where there is a wall that is shared by a mental hospital and a police station. On one side of the wall, electric shock is used as therapy. On the other side of the wall, it's used as torture. But what's interesting too is that there's no difference in the method of giving the electric shocks. The therapeutic in quotes side uses unmodified ECT, which means electroconvulsive therapy without the anesthetics, to counter the pain and the dangerous ill effects, including breaking bones and teeth, and this use of unmodified ECT has it happens quite often in India, not in all places. It has been justified by psychiatrists as being necessary because of the cost of anesthetics in a low-income country. It's true, they're relatively more costly there. And it's sometimes hard to procure them. So they decide, the rationalization is that sometimes ECT is a necessary intervention in a crisis situation where someone is suicidal and depressed rather, it's not only suicidal. And they need to do this, and even if the anesthetic is not available, it's still better than not doing it, is the rationalization. To me, that rationalization is part of the sort of hegemony of mainstream thinking in psychiatry, that sort of justifies practices like this that, from another point of view, from the other side of the wall in the police station, is seen as torture. And this other book, China Mills, I highly recommend it, Decolonizing Global Mental Health. It's a critique of the worldwide application of Western style psychiatry, and she discusses electroconvulsive therapy as a form of abuse. And she also discusses unmodified ECT as something that happens quite often in low-income countries, and how it should be considered a form of torture. It's a very powerful book. It also brings up as the title suggests, global mental health movement. So global mental health is just sort of a term, but it's actually the official name of an international movement that some of you may have heard of, called the Movement for Global Mental Health, that is based out at, well, but it is run by people at Harvard University and the London School of Hygiene and Tropical Medicine, and it attempts to bring the benefits of psychiatry to low-income countries, places that they feel are lacking that. There's sort of this justification that like they don't have enough treatment for mental illness and we need to bring them Western psychiatry to save them. I've tried to push back against that movement in my own writing by pointing to my research in India and saying, they actually already have Western psychiatry there, and they have Ayurvedic medicine. They have other interventions that they use for mental health, and they've used for a long time, and a lot of them are very effective. I know I've spoken to people. They don't need to be saved by more psychiatry, as it were. But nevertheless, the movement for global mental health has moved forward, expanding the reach of psychiatry through and expanding the reach of psychiatric medication. That's one of their main interventions, not to anyone's surprise, but they do also advocate other interventions, occupational, therapy and forms of talk therapy in addition to that, but psychopharmaceuticals is a big part of it. Okay, moving on. So I'll sort of transition to some comments about issues in the US here using this. Let me go back to Google Meet, make sure that that's on the screen. Yeah, so the Mental Health and Human Rights Report of the UN High Commissioner for Human Rights, the most recent one, which is 2018. I hope another one has not come out since then. This is the most recent one I find. And I put the link there if you're interested. Defines electroconvulsive therapy as a human rights abuse. Even if it's done with anesthetic, even if it's done the normal way. In a way, it's actually defining what I call the normal hegemony of psychiatry, the sort of normal, what's taken to be a common sense practice, use of ECT with anesthetics, the supposedly less controversial kind of use. And it is branded it as being a form of abuse or a form of torture. If it is done against people's consent, and it is often done by force without the consent of the subject. So in a way, official statement by the UN is at odds with what has become normalized practice in psychiatry. So forced ECT is used in India, and it's also used in the United States. There are many cases. There was one case as an example. A woman in Minnesota a couple years back was in mandated treatment, and a group of individuals from ISPS, which I think most of you are familiar with, the International Society for Psychological and Social Approaches to Psychosis, the US branch of that, got together and mounted an advocacy campaign on behalf of a particular woman who was being treated against her will in a hospital by the state of Minnesota. She was forcibly being given ECT, and we were encouraged to use many different paths in our protest, including writing to the senators and representatives of the state of Minnesota, and that's what I chose to do. I sort of use I think it's a really good use of our titles. When we have a professional title, I use my position as PhD expert on mental health and my university letterhead and wrote Congress people saying, I've done research on this issue. I think it's abusive and a violation of human rights to do this to this person. And furthermore, I attached that UN report saying that the UN declares that this is a form of torture when it's done against the will of the individual. And our campaign was successful. Legislators did intervene and discontinue. I forget the details. I don't think that she was released, but I think that they discontinued some aspects of the involuntary treatment. So one can, if one has a lot of allies with in the professions, one can, hopefully pressure and change this. But the problem is, again, this continues to be the sort of normal hegemony of normal psychiatry. It'll come up again and again as the normal practice to do something that the UN considers to be a form of torture. And then in an attempt to explain what's behind these different approaches in the US and in India. Now, this is something that's not worldwide. I don't claim to have surveyed worldwide practices of electroconvulsive therapy, but it is widely used in India and the US. And it can be done involuntarily in both places. I don't believe that's the case everywhere. If other people have other examples, I'd love to hear that. So I was trying to understand what might be the reason for such uses or abuses in both of these locations. And I have this term here, instrumentality, intervention, and insurance in the US. I think these are factors in the use of ECT and its normalization in the United States. So instrumentality is meant to refer to what I see as a cultural belief in the machine, that technical solutions can be the best solutions. I think there is a thinking along these lines that allows people to think that ECT is a especially powerful and effective intervention, especially in crisis. And then there's the term intervention. Some other people in medical anthropologists have described U.S. biomedical care as particularly interventionist, and they've given the examples of cesarean sections at birth. The U.S. does more C-sections compared to several different countries in Europe that were considered comparable to study for a variety of reasons. And the explanation for this is, that in American medical thinking, it is the intervention that is considered to be key in a therapeutic solution. Giving advice, changing something in a person's lifestyle is not the default solution in American medicine. A technical intervention is what I would say the hegemonic way of thinking. And then the insurance schemes, the private insurance that is pays for medical coverage in most of the U.S. today pays per procedure. Okay, so you get paid as a doctor, or moreover a hospital, I should say, or a clinic per procedure, not for thinking. If you're a doctor able to figure out a solution to a problem that's, maybe you should try this, or maybe it's actually not a problem, you don't get reimbursed for that. You get reimbursed for doing something, administering a medication, and especially even more for using a machine to do a procedure. So there's a financial incentive to do things like ECT in the U.S. And I don't want to imply that doctors are knowingly, just doing ECT, to get rich. I think it's more what I call the hegemonic, using Gramsci kind of thinking. It's just considered normal, and it's not just the individual doctor. They work for usually a larger organization, a clinic, and the clinic has a department that does the billing. And I think at the management level of the clinic, there ends up being sort of a pressure to use more billable methods that kind of trickles down to the thinking of the doctors. So it's not just, many people depict kind of, evil doctors wanting to get rich. It's not that simple. It's more of a institutional level push towards such interventions. And then in India, I believe there's something what I call developmentalism or developmentalist style of thinking that drives use of ECT. And this is something that anthropologists have brought up and even critiqued the whole notion of development. There's countries that are developing, underdeveloped, et cetera. This implies this kind of that everyone's trying to go to the same place, and that there's this race to the top, and people are at different stages of development. There's many critiques to this, including that not everyone is going in the same direction. Or needs to, and there's a lot of evidence that thinking in a developmentalist way is quite damaging, sometimes to local institutions. So there's a developmentalist thinking in India makes it such that people think that they need to be doing what the West is doing. They need to practice a variety of they need to do medicine, they need to do healthcare in the way it's done in Europe and the UK, and that is via Western medicine and via lots of technological interventions and medicines. Western biomedicine is seen as being all about medications, injections, machines, and so I would say there's an extra emphasis on that. And a belief in that the increasing use of technology and medicines will allow India to sort of catch up, as it were, and allows a place like India to overlook local forms of healing, such as the religious therapies or Ayurveda that actually have been useful for many people, as being backwards and undeveloped, and so that gets left behind. I would suggest, though, on the other hand, that there are things that places like the U.S. could learn from India and the forms of treatments that are getting left behind. The gentleness of Ayurveda, which patients appreciate. It's never perceived as abusive or painful by patients. Same thing with the religious therapies. It's all you're outside, singing, doing pujas, incense burning. It engages the senses in a very positive way. And I think these possibilities offer models of treatment that are quite different from these what I've called normalized abusive therapies, particularly ECT. Although one could also perhaps make a similar argument for heavy doses of antipsychotics being a form of normalized abuse in treatment in the U.S. and in India and perhaps in Europe as well. So I'll end there. I'm eager to hear comments, reactions, questions about any of this. Let me just stop sharing here. Yes, Hal?
Hiya. Thanks for the talk. Yeah, I'm interested. I read some of your early work, I think, around psychiatric pluralism many years ago, which was very influential to some of my work. And I don't know if it feels like you've moved a little bit on from that, but one of my questions really is about the reverse problem that you're raising, which is the kind of romanticization of indigenous healing practices. Because I know of quite a lot of Indian activists who are quite concerned about the kind of Western romanticization of healing practices, which can be very abusive, actually. So there are cases. I mean, we've covered, the Awadi hospital, where the fire, and that was a religious healing hospital,
right,
which was set on fire, and the patient.
Sorry, just a second. I have to look.
Sorry.
have to let the dog out. Sorry, he sits there and whines and just. Yeah, so yeah, please go ahead. Yeah, Irrawaddy.
Yeah, in Irrawaddy, the patients were chained to their beds in a indigenous healing kind of alternative hospital. Right. Many of them died. So I think we need to be careful about the reverse kind of idea that somehow Western medicine is all bad and indigenous healing methods are all good. You know, and I think your idea that I took from your work about pluralism felt really important. You know, that people had access to a variety of different possible kind of support treatments or whatever you want to call it. So just wanted to, if you had any thoughts on that, because I'm a little bit concerned about that sort of approach, which kind of can miss out on the abuse of, I mean, it's like therapies as well, which are often considered gentle, but actually can be very abusive. Psychoanalysis has got a pretty checkered history in the West as well. I'm not just talking about Eastern practices at all, but I just think we need to be really careful about not kind of doing another reverse binary or a kind of alternative Whiggish kind of history.
Yeah, no, good points. And I've followed those debates about Irrawaddy quite a bit, and they come up in the movement for global mental health literature. In fact, the movement for global mental health uses Irrawaddy as a justification for more psychiatry. And actually, I do have a different interpretation of all that. I mean, first of all, Irrawaddy was a traditional healing center. To me, it's a problem with fire safety. There was nothing about the healing system itself that put the people at risk. If there had been a fire at the mental hospital, biomedical mental hospital, where I also worked, patients there are also chained to their beds, and they would have been.
Yeah, sure, but I don't think being chained.
That is.
Sure, but I think they were chained to their beds, though. You can't deny that they were chained to their beds, and that's why they died. They died because they were chained to their beds. They couldn't escape.
Yeah, exactly. But not chained down. You know, actually, what they have is like a chain around the ankle, and then there's a certain distance of the chain, and it's so they don't leave. So in the mental hospital, they also use that method. So there's no difference in the method. It's the chaining, or they're incarcerated behind bars, so they can't leave. So it's in that case, I would say it's exactly the same. The indigenous healing system uses the same method of restraint that is used in biomedicine, and both places are subject, to fire risk. The other form of abuse. I mean, the psychiatrists I spoke to in India thought that there were abuses going on at the religious centers. And they mentioned, for example, Chaitanya Temple, where I went, and I actually did field work there. The psychiatrist told me that their priests will beat and abuse people with mental health problems who are, going into trance and things like that they will be forced to pound a nail into a tree with their head until they're bleeding. Was what I was told. And then I actually visited the place and found that wasn't going on. In fact, the whole thing that they describe is ritualized. So if the afflicting spirit won't leave after Kali has been invoked, right away the spirit will say that if you pound a nail of a certain length into this particular tree where Kali is supposed to reside, then I will leave this person. So they make a pledge to pound a nail into a tree, and I've watched them pound the nail. They place it with their head like this, and then they take a coconut and they pound it in. I mean, it's sort of the abuse wasn't actually real. It was like a symbolic thing. But the psychiatrist who reported this had never been there. It just kind of trickled through the psychiatric community that there was abuse going on. So while I've heard of accusations of abuse of traditional healers, when I have observed the traditional healing, I've not seen it myself. So I don't know if it's nothing more than psychiatrists, claiming. And at the same time, there is a problem with romanticizing traditional medicine. I would say, having seen them all, I would still argue that psychiatry is more abusive, and that abuse is more easily rationalized. And there's lots of studies of traditional healing. Carla Bellamy's excellent study of this Hussain Tekri Temple in North India, for example. Same issue there. People who, as you know, are you know, as a devotion to the Sufi saint who is interred there, will do things like chain themselves to a fence at the temple. You know, but they're doing that voluntarily. It's part of like their devotional practices. I'm going to put a chain around myself up to this fence, and I'm going to stay here for 2 days to show that I'm devoted to. And then that's branded as abusive. But I would argue that they're voluntarily doing that, whereas like ECT is done involuntarily. There, you know, and certainly, I would say in other health issues, you know, there is a danger of romanticizing indigenous medicine. You know, if people looked to Ayurveda for cures for AIDS and COVID, when they really had nothing that was effective. And I think that's a very different set of issues. So I you know, just having heard all this, I still go on the side of I think that allopathy is still more abusive. In the without saying that it's impossible that the others would be.
Yeah, Murphy, I'm interested in your mention of the idea of instrumentality as being one of the ways in which the hegemony happens. You know, this idea that, you know, high-tech interventions are the good interventions of machines. And it reminds me of the Soteria House. The original Soteria House was in San Jose, California, and it was actually a research project of the National Institute of Mental Health, run by Lauren Mosier, who was the psychiatrist, who at the time was the head of the schizophrenia research office at the National Institute of Mental Health. And you know, the way Soteria works is basically you have a home-like residence in which people experiencing psychosis come, and the message they get is, come on in, you can stay here as long as you want. We're going to just provide you with support, safety, and affirmation as you go through the experience, because we understand that even though it's impairing and it's troubling and scary and agitating, bizarre, somehow this is the way you're surviving. This is the way you're moving towards healing and recovery. So that's the model. The model is to help a person go through the experience in a safe environment, supported environment. Well, they did a very good study where they compared residents treated at Soteria with residents treated at the hospital in the more biopsychiatric approach, medications, etc. And what they found was that 2 years after treatment, the patients treated at Soteria were doing better, significantly better in terms of social functioning, employment, rehospitalizations, and symptoms. But the NIMH shut it down, and they fired Lauren Mosier, and that information also got buried in the NIMH. It's buried. It went into the black hole in the NIMH. And so, you know, because psychiatry was going towards medication, electroconvulsive therapy, et cetera, et cetera. So the problem of instrumentality is there because, Soteria is very low tech. I mean, it's so low tech. What we're doing is just helping this person go through the experience, and we're using relationship as our treatment. And it's so low tech. And I imagine talking to a psychiatrist, a recently trained psychiatrist saying, well, if you don't like he might ask me, if you don't like the drugs, what do you like? And I say, well, what about Soteria? There's evidence. And I tell him about it. And he says, I didn't go to med school for that. I'm a doctor. Anybody can do that.
Right.
And in some way he was right, because, the staff at the original Soteria House, it was directed by a licensed clinician, but the staff were non-credentialed people. Young people who could relate to people in a psychotic experience, who knew how to help people come down from emergencies, crises, et cetera, et cetera. Anyway, it's a problem. I think it is a problem. Some of the effective treatments, and I imagine even so-called talk therapy, for many people, say, how does that work? How the hell is talk therapy? Listening to somebody helping somebody understand their thoughts. You don't understand. It seems to be a problem, actually. I don't know what to do about it. What do you think?
That's no, those are good questions. I think that one thing you're bringing up is the whole, I would call it sort of the battle over evidence that's involved in a lot of these therapies. That you're saying that there's evidence of effectiveness of Soteria House, and that in the end doesn't seem to matter. I think we're seeing a similar thing over open dialogue. There's actually a lot of the team in Tornio has published articles that show effectiveness, and I think even there's been discussion of what counts as evidence-based. There's definitely, there's a big clinical trial, right, of open dialogue in the UK that may count as evidence, actually, in the mainstream debates. But I think that despite evidence, people can still push it aside. I think there's the instrumentality. There's the machine and medicine bias. So even if you do have evidence, evidence of talk therapy somehow tends to be overlooked. And we're going to go for the machine anyway because it's just compelling. Yeah, like you said, what did I go to medical school for? Many doctors and who do not choose psychiatry from right from the beginning, are first and foremost wanting to be heroic technicians. And in fact, I had a young doctor, family friend, staying with me from India earlier this year for a few months, and I got to hear all about him and his recent graduates from medical schools, elite medical schools throughout India. And, he would mention, friends he knew who wanted to go into psychiatry, not because of any interest in mental health. The decisions were all based on income and where there are opportunities, where you could get a residency and internship. And all of these students, they're all it's all the science model. They were not interested in talk. All of the publishing, a lot of these students do this thing where a lot of American doctors now outsource publishing to young Indian medical students or graduates, and these were the guys that did this writing. All of the writing on mental health is all about medications and other interventions that are instrumental, rather than there's no talk never came up as a topic. So I think I think that's a big issue. There's the power, at least I would say more so in the U.S. The idea of the technology and the machine as being a savior, I think, is a big factor in our thinking. We're not just looking at evidence. Certain evidence is more exciting than others. Anyway, just a few thoughts about that. Mia, did you have any thoughts about that? I think it's so interesting what's happening with open dialogue in terms of what I call the struggle over evidence.
We're not hearing you, Mia.
Well,
I think there's a
it's
problem
very
with. I think there's a problem with Mia's audio. We're having trouble hearing.
but
I think you're just.
No, we
you're
cannot
just.
hear you. Sorry, we cannot
Go
hear
on.
you, Mia.
You're coming in bits and pieces. Maybe it's a weak connection.
can you hear me now?
Yeah.
Okay. So I'm aware that there's not much time, but thank you very much. And I think that there are many people who are talking about the shift in paradigm in many ways, and open dialogues or open dialogue informed or inspired practices are taking place in many parts of the world. But this question about the evidence is always there, and who gets to define that? Who gets to define the designs for the research and so on? So that's a huge part of the conversation all the time. But I'm also wondering, because as we all have experienced from our point of views from different parts of the world, that the pandemic was really changing the life and perception of life in many ways for people around the world. I think it would be so interesting to because I think, at least in Finland, people are asking very different questions when they contact to the mental health services as they did before. There's much more kind of a hope for diagnosis or different kinds of definitions about their qualities or about the challenges they are facing. And that has been a very rapid change, at least in Finland, and we are discussing about that a lot. And that, again, is, for me, it is connected to the human rights and for example, the next week's launch that happens in WHO, when they are launching this new guidance on human rights and mental health legislation and policies. But yeah, many thoughts. Thank you so much, Murphy, for your presentation, and all the others for the comments. Very inspiring.
Okay, all right, thank you. Yeah, thank you for those comments. If I could actually ask just one final quick question. I mentioned that I'm not really aware of policies in other countries regarding whether ECT can be done involuntarily. Did anybody else have any observations whether in, I don't know, Finland or Spain or UK, whether places you know of, whether they're, what the laws are on ECT? And
no, as far as I know, from my 20-year experience in Finland, it is not possible to do ECT involuntarily. The legislation doesn't allow that. But then again, I don't know if there has been any changes, but not in my experiences.
okay, great.
In the UK, it can be given involuntary. Usually it's given to people who probably are considered unable to consent because they are usually very poorly, but you can definitely give it without consent for sure. I think you need maybe 2 medical psychiatrists to sign it off, but it's definitely possible to give it involuntary. I will say the justification is that it wouldn't, that people are no longer when they're given these, they're no longer in a position to give consent. But what we argue for in the UK is a kind of advanced directives, and to be able to say if you would or wouldn't, if you were so unwell, whether you would give or so, to make advanced directives more legally binding. Currently they're not, so that is a problem for sure.
Oh, Al, I think you're muted here.
Thank you. Mia, I didn't understand your point about the difference that occurred, or the change driven by the pandemic. Were you saying that patients now are more, they more want a diagnosis? They're more interested in diagnostic, allopathic, biomedicine, that kind of thing?
Yes, especially around neurodiversity. This is a big theme in Finland and in other Scandinavian countries as well. And as I have learned, I was meeting with the group from Brazil a few weeks ago, and they were talking about the same, that people, well, first of all, of course, because the so-called mental health problems or challenges, they were increasing a lot during the lockdowns. So people are suffering more at the moment, and that suffering is kind of defined as a mental health problem or psychiatric diagnosis. So people are contacting nowadays with more kind of focused question that, do I have this or that diagnosis, or I have been looking that I have this and I need your confirmation on that. So this is what we are kind of trying to figure out now here in Finland and in our services, that what do we do with these what are the needs that there are in among citizens at the moment? What are they hoping from the mental health services?
Yeah, so there's a whole thing about neurodiversity. people talking about neurodiversity, what are the interventions that are used for, if people say, well, I'm just neuronally diverse, what kind of intervention does a person want, or if they do want interventions? I don't know.
Yes, that's a very good question. Well, first of all, they want to have of course, there is diagnostical procedures for that. And then some people will want to have this is your diagnosis, and this is the huge question that we have. And I am not saying that these challenges aren't real. Of course, there are challenges and many ways to discuss and support that. It has been kind of exploding the need for these definitions that we need to rethink that what are we talking about here and how can we respond as a mental health system into these questions.
Mm-hmm.
I don't think the neurodiversity paradigm necessarily results in more medical interventions. I think neurodiversity paradigm introduces a social model of disability. So it's more about society making accommodations to people with neurodivergences rather than saying that they should be treated. And that would be the implication of a neurodiversity paradigm, as opposed to a medicalized paradigm of autism or whatever that's slightly different. So neurodiversity paradigm is a different paradigm to a medicalized one.
It could be used as a justification to push back against treatment, actually, to sort of say, I'm neurodiverse, I don't need the medicine or the...
But in Finland, it comes, at the moment, it does come to the psychiatry. Yeah. It's directly there. So this is very good point. Thank you. So it's something that should be discussed further here as well.
I think we're moving on to the next talk now, though.
Yeah.
Thank you, everybody.
Thank you.
I need to go to another meeting, unfortunately, but I'm sorry to miss the next talk.
Okay.
Thank you.
Thank you for your comments.
Thank you. Bye-bye.
Okay, I apologize. I was telling Peter that he can start his presentation. It is lovely to be able to have a debate and a conversation, and there is so much to say about the expectations. And does that coconut work? Only because, well, may they really be supporting that Soteria does in a way in which doesn't force them to believe that this is for life, like the belief system for getting Hinduism about the condition is that the recovery is possible. It doesn't matter the technique. It's hopefully not it's the coconut, hopefully not a diabetic coma. It's like, not that we have many better techniques here. But yeah, I just stop here. I introduce Peter. He's from Czech Republic. He's director of the mental health system there. Correct me if I'm wrong, Peter.
Oh, you're muted, I believe. We can't hear you.
You're muted, Peter.
I think he's unmuted now, but we're still not hearing him.
Yeah. Murphy, can you develop on that? I would like to know if you have studied the system there. Do you know if it still works better in the sense that there is recovery? I know that in other regions, the psychosis tends to be temporal. I mean, it is not for life.
Yeah,
it is the case there.
Yeah. I mean, in India.
Yeah.
Yeah. There's actually been a lot of research done on that, and I've written on that myself. That's a big story in itself. But yeah, there's India was one of the main sites in the WHO international study of epidemiology of schizophrenia, and had the best results of any place they studied. And I've been trying to explain why in some of my work, but I'll just say that for now. Just a quick answer.
Peter, we cannot hear you. Hello, Peter. I lost connection myself. I apologize.
He said he was going to log off and log on again to see if that helps.
Actually, something, Murphy, is the possession paradigm, the spiritual part of it. Yeah, I would love to read about your work on that, and if they differentiate, like the Vatican, since they have, or others that work also in that, there is a possession, but only in certain cases. What is the criteria to differentiate? If they do.
Yeah, no, that's a very interesting, issue in itself, and whether they really are equivalent. Well, now it looks like you're still on mute. I see the mute icon. Maybe what Mia said, something about you may need to give Google permission to use your microphone. Is there a prompt for that?
Murphy, can you see that microphone icon? Can you click on that? You're now supposed to be able to talk.
Oh yeah, no,
Sorry. I was looking at the wrong one. What is Peter now? He disconnected.
I think maybe he left again to try to come on again.
Okay.
Maybe did you make him a host? I wonder if that can help.
When he was around, yes, I did try, but obviously if he was going out and inside again. Well, how many years you were in India?
I guess altogether maybe 2.5, but in different trips, spaced out, like a year and then 9 months and then 3 months. So